Hello, guys. Thanks for attending. Today, we will continue our series about how to approach an SVT case in the EP lab. These are our main sources. And we already talked about SVT diagnosis specifically based on specific ECG findings. This was in part 1. And we talked about planning and performing a diagnostic and therapeutic EP study in part 2. And today we will be talking about maneuvers to be done to confirm a specific diagnosis in the EP lab, focusing more in AVRT, AVNRT, and focal atrial tachycardia rather than intra-atrial tachycardia. We will, because I have so many slides today, so I will be subdividing today's talk into 2 parts, okay? So we said before that reentry is the most common SVT mechanism, and reentry is a circuit that might involve 1 or 2 chambers, atria only, or atria and ventricle only, or ventricle only. So imagine you have a circuit here. With an advancing head and receding tail and piece of tissue that is non-conducting that the circuit is rotating around. So that advancing head, in order for the circuit to be sustaining, that advancing head is going to depolarize or meet cells that are already fully repolarized and ready for depolarization, such that it keeps advancing. Okay, and then by the time and then as it advances, the subsequent cells are fully repolarized and ready for depolarization, and hence the circuit keeps rotating around. Okay, so in this example, the solid line represents refractory cells. The circle represents tissue that is non-conducting, that the circuit is rotating around, and the blue rectangle represents something called excitable gap, which is a zone of tissue that is again fully repolarized and ready to be excitable or depolarized. And this is a must to sustain the circuit. Okay, and like we said, the circuit could involve both A and V at the same time, similar concepts. Okay, so now you have an SVT that is induced, and in order to study that SVT further, you want to pace slightly faster than the tachycardia cycle length to reach and hopefully excite the excitable gap and penetrate into the circuit. Okay, if you pace slower or very fast, you may not be able to reach the circuit, or you may terminate the tachycardia. So say that you pace slightly faster than a specific tachycardia and you were able to depolarize the excitable gap, hence you leapfrogged into the circuit, or you jumped into the circuit, and then that pacing stimuli would revolve once around the circuit. Okay, and then and if you were able to achieve that, this is called reset for that 1 beat. Okay, so again, if you capture the excitable gap and that your stimuli revolve once around the circuit, this is called reset for that 1 beat. And if you repeatedly or continuously repeat this maneuver, this is called continuous resetting or entrainment of the tachycardia. What determines how easy it is to reset a specific tachycardia is the size of the excitable gap. The larger the size of the excitable gap, the easier it is to penetrate the circuit and then reset the circuit. The proximity of the pacing site to the excitable gap, if you are close to the excitable gap, it is obviously easier to excite that zone of tissue. And if there are any barriers between your pacing site and the excitable gap, then it's more difficult to penetrate the circuit. So another way of studying a specific SVT circuit, more specifically for AVRT circuit, is delivering a ventricular stimuli at the time when His is refractory, i.e. His refractory PVC. And if you deliver such stimuli and you note an advancement or delaying, so any change in atrial timing, or if you actually terminate the tachycardia, but you want to make sure this is repeated, so that's not coincidental. This is, i.e. you reset the tachycardia, and that proves presence of an accessory pathway, because again, if the His is already depolarized and you deliver a pacing stimuli that at the time when his is refractory, there is no way to advance or change the atrial timing except through extranodal connections, i.e. accessory pathway. So now you proved the presence of an accessory pathway, and if that atrial activation sequence remained the same, then you proved that the SVT mechanism was in fact accessory pathway related, and the diagnosis is indeed AVRT. If you repeat this maneuver continuously, this is called, again, entrainment of the tachycardia, okay? So while you do his refractory PVCs, you may want to note or calculate the pre-excitation index, which is the tachycardia cycle length minus the longest or the latest his refractory PVC that actually was able to pre-excite the atria, okay? So when you do that, if your index is more than 75 and you're actually pacing from the RV apex, then this suggests a distant accessory pathway, i.e. on the left side, because you need, so again, you're pacing from here, your accessory pathway is very distant from you. You want to pace really fast with a short coupling interval to actually leapfrog or jump ahead of the orthodromic beat. Okay, so if you have to pace really with a short coupling interval, hence your tachycardic cycle length minus that interval would be long or large, and hence usually it's more than 75. Okay, and if you have an acceptable accessory pathway which is the closest to your pacing site, then the number would be the least, okay, less than 45. And then any right side accessory pathways are between 45 and 75, the difference in right accessory pathways. Okay, so also while you pace into the tachycardia, you want to note fusion and of your pacing stimuli with the intrinsic QRS, native QRS tachycardia. And if you note fusion, and this fusion also is simultaneously resetting the tachycardia, so you note reset and fusion at the same time, this means that the circuit has an excitable gap with separate entrance and exit into the circuit, i.e. Again, you have a circuit. Let's say this is your exit from the circuit, and this is your excitable gap, i.e. entrance into the circuit. They have to, if you see, when you pace, and you might fuse with the exit from the circuit, and you will reset, meaning enter into the circuit, and you revolve once around the circuit at least. Then if you note both, then there is separate entrance and exit. Because for example, if you have a focal tachycardia, the entrance and exit, they are not separate, because the exit is everywhere, right? And hence when you pace, you will collide with the exit, okay? So you will never be able to reach the focal origin, except if you pace way faster than the focal origin, such that before the exit, so you go into the focus before it actually depolarizes. Okay, so you will not be able to demonstrate reset and fusion with focal tachycardias. However, you will be able to demonstrate reset with fusion with macro reentry tachycardias, okay, or reentry tachycardias. And the fact that you note fusion, this by default means that your pacing stimuli was His refractory, because if you look at this diagram, you say you delivered a stimuli that is His refractory, meaning after the tachycardia QRS exited the His, then and then you repaced, then you will obviously, your pacing stimuli will fuse with your tachycardia beat, and then you will note fusion. So if you see fusion, you know that the tachycardia beat already exited the His, and hence there's already intrinsic QRS depolarization, and hence it's definitely and hence when you see fusion, you know there is it's equal to his refractory PVC. Okay, so again, if you see fusion, you know that there has to be some intrinsic QRS from the SVT beat plus the stimuli plus your pacing stimuli depolarization, and hence you know it's his refractory PVC. Okay, otherwise if you pace and you don't see fusion, then you know you paced before the his has actually depolarized and it's not his refractory PVC. Okay, so so in this example, you have a septal accessory pathway. You deliver pacing stimuli at the time when his is refractory. Like we said, you will demonstrate fusion and you will leapfrog into the accessory pathway, and the circuit would be, your atrial timing would differ, usually accelerated, because you shortcut the circuit. You know, instead of the circuit going all the way down and then all the way up, you paste here, so the circuit goes down, and then you paste from here, and then the circuit goes up, and then it goes down, and you paste from here, the circuit goes up. So as if you shortcut the circuit. Okay, for AV NRT, for example, you have to pace really fast in order to get into the circuit, i.e. not his refractory MR. So you have to pace as that this pacing similar goes up, retrograde across the his into the circuit, and then it turns around. Okay, so you cannot, in order to get into the circuit, you cannot have his refractory PVC that gets into the circuit in AV-NRT. Okay, because again, you have to pace fast and you have to go retrogradely up the his and then enter the circuit. Okay, so when you note fusion and reset, this is very helpful to distinguish specific types of SPT. So this is only possible in AVRT, not in atrial tachycardia or AVNRT. Similarly, in atrial tachycardia, you have a focus here. In order to get to the circuit, you have to pace fast. You retrogradely go up the his and then into the circuit. Okay, so you will not be able to fuse. Okay, so so when you note fusion and reset, this is called manifest entrainment, and that proves the re-entry mechanism, proves an accessory pathway is present and participating in the tachycardia, proof that the ventricle is part of the circuit. One, obviously you're pacing from the V in AVRT cases, and that excludes AVNRT or atrial tachycardia, because again, you will not see fusion with reset at the same time. You will only you might fuse, but without resetting. Okay, but you will not. It's not possible to fuse and reset in atrial tachycardia or AVNRT, because you have to pace fast. You go retrograde up the his into the AVNRT or atrial tachycardia circuit, so you will not be able to fuse. Only the fully paced QRS. And for AVRT, just of note, for left lateral accessory pathway and you're pacing from the right side, you may not be able to demonstrate fusion and reset just because you are further away from the accessory pathway. Hence, you might need, in order to jump ahead and shortcut the circuit, you have to pace relatively fast. And when you pace relatively fast, it might not be his refractory anymore. You might go retrograde up the his, right? So you might not be able to demonstrate reset with fusion for left lateral accessory pathway if you pace from the right side. However, if you pace from the left side in left lateral accessory pathway, then again you will be able to demonstrate reset and fusion, because you don't have to pace very fast anymore. You can deliver pacing stimuli. His is refractory, and your pacing stimuli is here, and such that it will fuse with your SVT QRS, and then you will shortcut the circuit as such. Okay, so one other thing that you know during pacing into an SVT tachycardia is the transition. What happens during the transition zone, which is defined as the first pacing stimuli that captures the V and ends with the fully paced QRS morphology. Okay, if you note atrial reset during the transition zone, again, this is AVRT, because you had seen you are fusing and resetting the tachycardia. Like we said, it's AVRT. If you don't see atrial reset during the transition zone, then it's most likely you were unable to fuse and reset that tachycardia. Then again, it's more likely it's AVNRT or tachycardia, or maybe it's a very far away accessory pathway from your pacing site. So let's just show one example here. um, you you this is a the patient who's having regular narrow complex tachycardia, longish RP, these are your A's, okay, regular, and then you are V pacing, okay, earliest A is at the his, okay. So you V pace, this is your first V pace stimuli. You note that the QR has changed, hence you captured the V, and in this case, the QR is not very wide. Then you definitely fused with the native QRS tachycardia, and hence this was a His refractory ventricular stimuli. However, that first beat did not advance or reset the A. The A to A timing remained the same. You delivered another ventricular stimuli, similar rate. That ventricular stimuli depolarized or fused further with the tachycardia QRS. And this pacing stimuli actually advanced the A, okay, with similar atrial activation still earliest at the his, okay. So you demonstrated here fusion with reset, okay, and then the third beat and the fusion beat and the fourth beat is actually the fully paced QRS. So your transition zone is from here to here, and you were able to fuse and reset during the transition zone. Again, it's an APRT, in this case probably a right-sided accessory pathway, okay. So you again you fuse with reset, it's now his refractory PVC. You advance the A with similar atrial activation, then accessory pathway is present and is participating in the tachycardia, okay. So again, for entrainment, you you have to demonstrate or observe fixed QRS fusion at a given cycle length, and that fixed fusion varies at different cycle length. So if you pace at two different rates without interrupting the tachycardia, and both rates demonstrate fusion, that's definition, one of the definitions or requirements to demonstrate entrainment. Okay, that constant fusion is not possible with focal tachycardias because, like we said, you only will demonstrate fully paced QRS when you reset the tachycardias for focal atrial tachycardias when you're V-pacing, okay? Or in AVNRT, which is like a very small micro re-entry or focal micro entry, or as if it's a focal tachycardia within the AV node, you will not be able to demonstrate fusion reset because again, you have to retrogradely depolarize the his into the circuit, okay? So, we already had mentioned this before. So with entrainment, it's simply put, it's a pacing maneuver that is applied during macro entry tachycardia to determine whether a pacing site is part of the circuit. And for focal tachycardias, you will not be able to entrain, rather you would overdrive the tachycardia, because the focal tachycardias have the same entrance and exit points, and you will only be able to overdrive the tachycardia, i.e. pace much faster than tachycardia, such that it gets inhibited, okay? But you will not be able to demonstrate reset with fusion, okay? So also with entrainment, like we said, you want to pace slightly faster than the tachycardia, not only to prevent termination of tachycardia, also to minimize the potential for decremental conduction, which might confound or confuse your calculations, okay? And you want to, if you're doing ventricular pacing, not just his refractory PVCs, you want to pace long enough to achieve a steady state, okay? And some people would take advantage of entrainment to stabilize the tachycardia that keeps interrupting, to better map the tachycardia. Anyway, so now imagine you paced into the tachycardia, you reset the tachycardia or entrain the tachycardia, and then you obviously at some point you'll turn off pacing and determine the post-pacing interval, okay? So again, you have this circuit. Say you are pacing at a site which is only 10 milliseconds away from the excitable gap. You were able to depolarize the excitable gap, and then that stimuli revolve once around the circuit, and then that stimuli obviously would continue, plus would exit towards the pacing site. Okay, and it will arrive to the pacing site after 10 milliseconds because it was 10 milliseconds away. Okay, so so that's an example, and I'll tell you why is this important. Just before I say that, in order to interpret the post-pacing interval right, you wanna reset the tachycardia or accelerate the tachycardia to the pacing cycle length, including the last beat, i.e., when you're V-pacing, you wanna make sure the last V-pacing actually accelerated the last A. Okay, not just during the tachycardia, but also during, meaning during and the last last beat, because this is the last beat when you use for calculation. So you want to make sure the acceleration was happening throughout the pacing. Okay, to achieve a steady state, but most importantly, the last beat should be entrained. Okay, and you want to make sure that the car did not change or did not terminate during or after pacing. Okay, so back to this example. So in this case, the PPI is what? It will be around 20 milliseconds because it took you 10 milliseconds to go into the circuit and 10 milliseconds to exit the circuit. So that's 20 milliseconds extra than your tachycardia cycle length. Okay, so post-pacing interval would be 320 in this case. And so then you are 20 milliseconds, it's 20 milliseconds, extra or longer than the tachycardia cycle length. So you're around 10 milliseconds away from the circuit. Okay. If you are truly in the circuit, your PPI we should equal the tachycardia cycle length. Otherwise, you're a little bit outside. Okay. This is for intra-atrial tachycardias. Okay. Remember, it also depends on the conduction time, meaning if you are close to the circuit, but the conduction is super slow, you might get long PPI. Doesn't mean that you are very far from the circuit. It might mean that the conduction time is slow as well. So this might confuse the picture a little bit because it's not purely distance. Okay. For AVNRT and AVRTs, you have different values that demonstrate whether you are in or out the circuit, and obviously you have to measure at the pacing site. Okay, so and I'll explain. I'll show these numbers in a second. So now you imagine you have SVT and you want to entrain from the V. Okay, so for atrial tachycardia, when you entrain from the V, again you have to pace fast, so you will overdrive the tachycardia with different atrial activation, meaning you have focus here. Okay, so you will pace fast. You will go up the His. You have to go up the His to infiltrate the circuit. Okay, the focus. Okay, so you'll have different atrial activation than during tachycardia, because during tachycardia, your atrial activation will be this way. During V pacing attempt, you will have different atrial activation. Okay, so you will overdrive the tachycardia with different atrial activation, and the post-pacing response will be VAAV response, meaning this is your last V pace. You'll go V to A, and then tachycardia A down to V. Okay, so VAAV response. However, for AVNRT, again, you have to pace really fast. You'll go up the His retrogradely into the circuit and then turn around. Okay, so you will not demonstrate fusion reset. So in other words, it's very difficult to prove entrainment in AVNRT. You will see V, A, and V response. Okay, for AVRT, you will actually demonstrate reset with fusion, and you also will get V, A, V response. Okay, you might for HS tachycardia demonstrate VA dissociation. You might for AVNRT demonstrate VA dissociation because technically the V is not part of your circuit. However, for AVRT, it's not possible to demonstrate VA dissociation because V is part of your circuit. Okay, the stem to A versus V to A difference is long in AVNRT because the AVNRT circuit is is um, sorry, just a second. So because the AV NRT circuit is a circuit that runs in parallel, meaning you are rotating around the AV node, you're going up into the A and down into the B almost simultaneously. Okay, so the this is during tachycardia. When you're V-pacing into the AVNRT, you'll pace very fast. You will change the circuit into parallel, meaning you will have V and then all the way up into A. Okay, so your V to A distance would be very large, and your stem to A and your sorry, during tachycardia, your V to A distance is very small, usually less than 70 milliseconds, but your stem to A distance is very large. So you'll get a large number. Okay, again, stem to A meaning from B to A is large. Okay, and tachycardia V to A, it's simultaneous, so it's very short. Okay, so get a large number. For AVRT, you say you have left accessory pathway, so you are or right, let's say right accessory pathway, so the circuit is going up the accessory pathway, down the AV node, up the accessory pathway. Okay, so your stem to A versus V to A, it will be very similar. Okay, so the difference would be less than 85. Okay, and the PPI minus the cardiac cycle length for AV NRT would be large, like we said, because you're V-pacing and your circuit is in the A. Okay, so you're far further away from the circuit, your PPI minus the cardiac cycle length would be large. However, for AVRT, the V is part of the circuit and your PPI minus tachycardia cycle would be small. Like we said in intertachycardia, the PPI minus tachycardia cycle, if you're actually in the circuit, is like close to zero. Same thing here for AVRT, because V is close to the circuit, it's short. AVRT, the V is away from the circuit, so it's large. Okay, and I will explain the why is it large furthermore and short in a second as well. So with atrial tachycardia, like we said, you might demonstrate fusion without reset or overdrive, or you will demonstrate fully paced QRS with overdriving of tachycardia. This is the otherwise it's not possible. For AVNRT, you might demonstrate fusion without entrainment because difficult to prove entrainment, or you will demonstrate fully paced QRS with entrainment or overdriving of tachycardia if you think of the AVNRT as focal tachycardia. If you think of AVNRT as microentry, you will call it entrainment. For AVRT, you will demonstrate fusion and reset at the same time. Okay, so the PPI minus the cardiac cycle length and stem to A minus VA, just really quick here. So again, like we said, if you are in AVRT, this is your pacing stimuli, you paced, you went up the accessory pathway and down the AV node, okay? So the PPI would be that distance, which is similar to the tachycardia cycle length, okay? So it will be short, okay? For and then your stem to A versus tachycardia V to A would be the same or similar, okay? For AVNRT, now you are V pacing into the circuit. You pace very fast. You went up the his retrogradely into the circuit. You turned around and then you came back, okay? So you have your PPI would be this distance from here all the way up to the AV node, and then from exiting of the AV node all the way down to this your pacing side. So it will be large difference, okay? So and versus your tachycardia cycle length is here. So you'll have extra timing, okay? And your stem to A, like we said, is this, and your V to A is very different, okay? Okay, so you'll have, it's this is why, this is how the numbers are being explained. So one thing you could do as well, you can pace the apex and the base and see what happens with the PPI and stem to A minus V to A. So for AVRT, if you pace closer to the accessory pathway, meaning at the base, whether it's right or left, your PPI minus tachycardia cycle length would get less because you are again closer to the circuit, okay? Okay, so that you get shorter PPI minus tachycardia cycle length and less SAVA difference. If you, for the AVNRT, it's the other way around. If you pace from the base, you are further away from the circuit because you have to go down and then up. Okay, so you'll have greater PPI minus tachycardia cycle length and more SAVA differences. So base apex spacing might help you figure out, mostly if you have septal or AVNRT mechanism. Okay, so when you demonstrate in numbers suggest in the circuit, you usually are actually in the circuit. But when the numbers suggest you are out of the circuit, then actually you might be in if there is an decremental conduction within the circuit, okay? Or you're pacing very far away from the circuit, such as when you're pacing from the RV and the access pathway is on the left side. Obviously, you have to repeat the maneuvers to confirm such findings and numbers. So to summarize, we had described so far excitable gap, pre-entry circuits. We said what reset means, which is an extra-stimulus depolarization that advance, delay, or terminate tachycardia. We said that entrainment means repeated resetting of a re-entry tachycardia by each of a consecutive beats once the excitable gap has been captured. We said overdriving of the focal tachycardia means you're pacing faster than tachycardia such that the tachycardia is inhibited and then overridden. And then we said fusion is when the extrastimulus depolarization fuses with the tachycardia depolarization. So we will pause here and we will continue with part 2 in just a second. Okay, so we just ended part 1. Now we will continue with part 2 of the lecture. Thank you for staying with us. So this part 2 of the lecture would be mainly about examples. Okay. Let me just. Okay. So this is one example, or the first example. So it's a regular complex, narrow complex tachycardia, long RP, that is the P-wave candidate, and EGMs confirms it's a long RP tachycardia. You let me orient you here. You have lead 1, 2, AV1, and HRA catheters, his CSs, proximal to distal with an RV catheter. Okay, so you have AHV, nice AHV in your his catheter. The H to H and the A to A interval, the tachycardia cycle length is 375 milliseconds. You deliver a His refractory PVC because the His here looks exactly the same as the antegrade or orthodromically captured His, and it came on time. So you delivered a ventricular stimuli just before the His depolarized, and you did not alter the time of the His. So you know it's His refractory PVC. You see change in QRS. You captured the V. The QRS looks different than your native QRS. It's not super wide. So most likely it's by definition it's a fusion beat because again it's His refractory PVC, and it's not very wide. It's not the super wide QRS like you expect with fully paced QRS. And then what that stimuli did to the tachycardia is that the next subsequent A is delayed to 405 with similar atrial activation sequence. Okay, so being earliest at the proximal CS. Okay, so that's your atrial activation sequence here. It's very similar. So it did not change your atrial activation, and then the tachycardia continued. Okay, so what we learned so far is long RP tachycardia, regular tachycardia, superior axis P wave because negative in lead 2, narrow complex tachycardia, earliest is at the HRA, not proximal CS. There's antegrade His. HV is normal during tachycardia, so it's not big sided tachycardia. It's a His refractory PVC. There is manifest entrainment, fusion with reset, the specific there was specific delay in atrial activation as the specific type of reset in this case. So there's decremental accessory pathway that is present. The V is fused, and hence V is part of the circuit. PPI minus tachycardia cycle length around 90. And after correction of the AH, after correction of the delay, with the subsequent to the his refractory PVC. And there was VAV response and tachycardia continued. Okay, so it's most likely AVRT that is involving right accessory pathway. Okay, another example here. So it's a right bundle branch block tachycardia, again longish RP. The P is beyond the QRS, more than 70 milliseconds. Okay, earliest A is at the distal his. The tachycardia cycle is 336. Okay, you don't have a very nice H signals, but this is your H, V, A, H, V, A, H, V, A, H, V, A. There's the catheter is probably not super stable. Okay, and then there's your H here, VA, and then this is your H. So the H to H interval, this is your next expected H, and this is your antegrade H that came on time at 336 milliseconds. You delivered a stimuli just after the his. So again, it's his refractory PVC that resulted in fusion complex, narrow complex, with resetting of the tachycardia being at 300 milliseconds versus at 336. So again, longish RP, regular right bundle branch block tachycardia earliest at the his. Antegrade his, like we said, HV is normal, not pre-excited tachycardia. His refractory PVC, there's manifest entrainment, there's advancement with the same atrial activation. Hence accessory pathway is present, and if there's also fusion, hence V part of the circuit. PPI minus tachycardia cycle length was around 60, and VAV response, and stim to A minus V2 was around 17. Also just tachycardia continued, also tachycardia continued, also just of AVRT, in this case maybe septal pathway. Another example. So maybe another right bundle branch block tachycardia. And again, you don't have very nice his signals. This is your his. This is your his. This is your his. Okay. So you are delivering ventricular burst pacing during the not his refractory PVC only. It's just in this case there's burst pacing that's slightly faster than the tachycardia cycle length. And this is the first pacing stimuli. This is the second pacing stimuli without any change in QRS, and it occurred after the QRS by a distance. That's your third pacing stimuli without a change in QRS. That's the fourth pacing stimuli with definite change in your QRS. So you know this pacing spike actually captured, and it's narrow complex beat. So, or narrowish complex beat. So you know it's fusion. So this is fusion beat number 1. Tachycardia cycle length is around 340. Okay, so that's your his. Like we said, you delivered the stimuli beyond the his, so it's his refractory, and you did not alter the timing of the A with this fusion beat. However, with the next fusion beat, again, this is your his. It came just immediately after the his. This is your his. You paste here, and you definitely fused, and the A to A interval, or the subsequent A came in, it was advanced. So this is fusion with reset. However, the tachycardia thereafter terminated. Okay, so in this case, it's not really narrow complex right bundle branch block tachycardia. It's regular. Sorry about this. Longish RP, earliest A at the his. These are your These are your A, so definitely earliest A at your His. So there was evidence of His refractory PVC that advanced the A with same atrial activation. And because that His refractory PVC was beyond the His and was able to advance the accessory the atrial activation story, you know that the pacing stimuli is very close to the accessory pathway, hence it's probably right-sided. Okay, so there's fusion, there's reset, so there's manifest entrainment, there's accessory pathway that is present, there's fusion, so V part of the circuit, stim to A minus V to A is around 9. So it's right-sided accessory pathway. Okay, because the tachycardia is terminated, you might not be able to tell whether there was VAV response and so forth. And another example. So narrow complex tachycardia, again, long RP tachycardia. You have a nice, in this example, you have nice AHV signals. You paced at the time when you paced exactly on time with the His. So His refractory, you fused, you did not go into the A and you terminated the tachycardia. If this happened repeatedly and not coincidentally, you know that you somehow altered the circuit. And because you altered the circuit at the time when His is refractory, so you know there's an accessory pathway that is present. So long RP tachycardia, regular, narrow complex tachycardia, earliest A is at the His, or yeah, at the His. So there's antegrade H. H came on time and with similar morphology, so you know it's orthodromically captured His. If you captured the His retrogradely, then the His probably would change in morphology. So this is another evidence that the His was antegrade. Not pre-excited tachycardia, His refractory PVC terminate without conducting to A. So you know it's not atrial tachycardia, there must be accessory pathway present and there's fusion, so hence B is part of the circuit. And again, in this case, probably right accessory pathway. Okay, here another example of pacing. This time is burst pacing, slightly faster than during tachycardia. But in this case, you are pacing from the LV. Okay, so there's your surface ECGs. There's your an LA catheter, His, and RB catheter. So you're pacing at 320 milliseconds. You are accelerating the A to A interval to the pacing interval at 320 milliseconds. Okay, so that's your pacing stimuli just before the His. So it's His refractory PVC. You are and again the His morphology looks the same as without pacing, so you know it's orthodromically captured His or antegrade His and His refractory. So you're V pacing. The earliest A, so this is, by the way, your A, because this is a clean A, this is how it looks like, and this is your V, complex V. So VA, earliest A is at your LA. So VA, VA, and then VA, AH, VA, and then you stop pacing and the tachycardia continues, AHV, and then VAAHV. Okay, so the earliest A, like we said, is in the LA. Okay, so when you stop pacing, the tachycardia went back to the baseline cycle length at 340. The AH during pacing and during tachycardia is different. So there was a decrementation of AH during when you're pacing a little bit faster. So they have to take this into account when you do your measurements. And the PPI was 430, and there's VAV response, right? So, and this is, by the way, your fully paced QRS complex. This is how it looks like, and and during pacing here, you see fusion. It's not fully paced QRS. So again, fusion with reset. This is what you're seeing here. So again, a sign of accessory pathway that's present. So it's long RP tachycardia, it's regular, and narrow complex tachycardia. Earliest A is at the left lateral, There's antegrade his, AA accelerated with the same activation pattern during ventricular pacing. There's excessive pathway present. HV is normal, so not pre-excited tachycardia. There is fusion, so V is part of the circuit. PPI minus tachycardia cycle length around 30. After correction for AH delay, like we said, so there was VAV response, so last beat entrained but not fused, and tachycardia continued. So again, left AVRT with left-sided pathway. Okay, another example. So there is narrow complex tachycardia, and you're V pacing, and the QRSs are narrowish, so you know you're most likely fusing. You're fusing during the ventricular stimuli. You're burst pacing here slightly at 400 milliseconds, and tachycardia cycle length at 420 milliseconds. You accelerated the A to the V rate, and your A2 activation is similar. Okay, so that's your V to A, and then V to A, and then you stop pacing, and then A comes down to H, and then V, and then A, H, V. Okay, so earliest A is in distal CS. Okay, so what we learned so far, so we fused, we reset the tachycardia, it's eccentric atrial activation, there is AVRT that is present, or excessive pathway that's present. V is part of the circuit. So long RP tachycardia, okay. Narrow complex tachycardia, earliest A at the left, on the left, AA accelerated with eccentric atrial activation. Excessive pathway is present. There's fusion. V part of the circuit. Stim to A minus V2 is around 75. You know, larger numbers because you're pacing from the right side, and it's actually left-sided pathway. PPI minus tachycardia cycle length is around 120 again because you're pacing from the right side, and it's a left-side accessory pathway. There's VAV response, and the last beat entrained but not fused, and tachycardia continued. Okay. Another example here, you're V pacing during tachycardia. Pacing cycle length around 370, and the tachycardia cycle length around 390. So what you note here that the atrial activation during tachycardia is different than during pacing, right? So during tachycardia, his, I think this is, his A is earliest. During pacing, maybe proximal CS is earliest. So you actually did not entrain the tachycardia. You rather, when you're V pacing, you over drive the tachycardia at 370 milliseconds, and then when you start pacing, you're seeing VAAV response with a long PPI. Okay, so narrow complex tachycardia, long RP again, or longer HRP, you actually overdrive the tachycardia because there's different atrial activation. The AA, however, is accelerated to the pacing stimuli, but there was VAAV response. Earliest A at the HIS or HRA, I can't really see this very well. So maybe it's HRA. PPI minus tachycardia cycle is around 300. So you're not in the circuit, okay? You are, it's an atrial tachycardia and you're V-pacing, okay? Okay, another example. Your burst pacing at 340 milliseconds, you accelerated the A to 340 milliseconds. And then the atrial activation during pacing is definitely different than your atrial activation during tachycardia. Okay, so there's VAAV response after pacing had been stopped, and and when you pace the QRS here, the QRS complex looks very wide. Okay, so it's not suggestive of fusion. Similarly here, by the way. Okay, so it's a long RP tachycardia, inferior P wave axis. Looks like the P wave is maybe positive in the inferior lead, so it's going towards the inferior axis. So you overdrive, there was ventricular overdrive with different atrial activation, and however, AA was accelerated during ventricular pacing. You do see VAAV response, and earliest A at the HRA during tachycardia, obviously, and the PPI minus tachycardia cycle length is large. hence because it's an atrial tachycardia and you're repacing. Okay, it is one of our patients here that one of my patients here that had one-to-one tachycardia with an eccentric atrial activation, earliest being at around CS5-6. And when we attempt to ventricular pace during the tachycardia, we were able to dissociate the V from the A. So the A to A, we're pacing at 300 and the AA remained at around 330 or 325. So an example of VA dissociation, hence it proves that's an accessory atrial tachycardia, sorry. And in this case was near to the left superior pulmonary vein. Further examples. So here you are V-pacing, burst V-pacing at to 80 milliseconds. You were able to accelerate the tachycardia, the A to A interval to the ventricular stimuli interval, and the native, and then after you stop pacing, the tachycardia resumes to the native, to its native cycle length. With ventricular pacing, you note narrow QRS, and very similar to the tachycardia QRS, however, with subtle changes. So there is definitely evidence of fusion. So you're fusing and you are accelerating the A with similar atrial activation sequence. So you know there's entrainment with fusion. So V, A being earliest at the proximal CS, and then H, and then your V came just after your H. So again, his refractory PVC as evidenced by fusion with reset, and antegrade his. Okay, so this is your his antegrade, and this is your his during pacing. It looks similar. Okay, so and then the AH during pacing is 135, and during native QRS is 130. So there's 5 millisecond difference that you have to take note of. Okay, so it's narrow complex tachycardia, longish RP, earliest at proximal CS, like we said. There's antegrade his, there's HV that's normal, not pre-excited tachycardia, AA accelerated the pacing stimuli. There's fusion, so V is part of the circuit with reset. In this case, there's there is subtle fusion, but by definition it's manifest. So there's excessive pathways present. Stim to A minus V to A is 10. PPI minus tachycardia cycle is around 20. So you are close to the circuit. It's VAV response and last beat entrained but not fused, and tachy continued. Okay, so in this case there's probably a septal accessory pathway. Okay, and then this is the same patient. You're V-pacing slightly faster at 270 now. Okay, the QRS complex change, still fused, but change. So there's progressive fusion, like we said before in part 1, which is one of the signs of entrainment of the tachycardia. So again, similar atrial activation. You sped up the A to 270 milliseconds, similar to the pacing stimuli. And your AH difference changed because there's decrementation normally when you're pacing faster, obviously. So take this into account. So there's still similar atrial activation. Everything is the same. AA accelerated the pacing cycle length. There's fusion. There's reset. There's manifest entrainment in this case. Excessive pathway is present. SA to and VA difference around 20. PPI minus tachycardia cycle length is 225. VAV response and again septal accessory pathway. So far what we said is so far we talked heavily about entrainment, and you want to just make sure that when you're pacing, the tachycardia accelerates to the pacing cycle length, and when you stop pacing, the tachycardia resumes after pacing at the initial longer cycle length. Okay. And you have to make sure you identify the last accelerated atrial EGM when you're repacing, and count that as the first atrial response after pacing. Otherwise you might risk pseudo AAV response, or you might confuse the post-pacing response whether it's whether it's VAV or VAAV response. Okay, and I'll show you examples. So when you have, it's especially confusing when you have decremental conduction that is present, and I'll show you examples. Okay, so also be aware that you are actually capturing the V, and the tachycardia, you're pacing faster than the tachycardia, and the tachycardia did not change, such as you might be algorithmically dissociating the V's and A's because you are V pacing, and the tachycardia, your V pacing may be just ever so slightly faster than the tachycardia, and you're not actually and you're not actually involving or accelerating the A. So again, when your pacing cycle length is not short enough, or when the tachycardia cycle length short is just before during pacing, so that 1-to-1 VA conduction during pacing is not present, and tachycardia and pacing train are just isorhythmically dissociated. If there is multiple tachycardias, it might be confusing, obviously. So this is one of our patients as well. We are V pacing. Obviously, you can see that the QRS is wide during V pacing. Doesn't look like it may not be a fused QRS. It's very wide QRS. But in any case, the A to A interval during V pacing accelerated to 420, and the pacing is the pacing cycle length was at 420 as well. And this is your last pacing stimuli. So this is your V, and that A came in at 420. So this A was actually as a result of this V. Okay, so VA. So that's your last A. So it's a VAHV response or VAV response. You might, at the time, some people were confused that this V caused this A, so we actually had VAAV response, but it's an example of VA V response, and this pathway was decremental, and hence maybe it was a little bit confusing. So for the long RP tachycardia, and earliest A at the HIST, AA accelerated to the pacing cycle length. Stim to A minus B2 was around 90. PPI minus tachycardia cycle length was around 160. There was decremental properties of the accessory pathway, hence the longer PPI minus tachycardia cycle length. There was VAV response, not VAAV response, and tachycardia continued with AH, and I'll tell you why AH is important to note here. Okay. It was right anterior accessory pathway. It was a very funny accessory pathway. So that V went up the A and then went down the AV node and back to the V. Okay. Another example here is that your V pacing, again, wide QRS. Okay. Your P pacing at 360, your A to A interval was at 360, your tachycardia cycle length was at around 380. So VA, and then you see this A came in at 360 at the exact at the pacing stimuli interval. So this V actually caused this A. So this is an example of not VAAV response, rather it's VAHV response or VAV response. So you have to be careful. You have to always see, make sure that you always have to identify the last A that is accelerated to the pacing cycle length, and in this case was this A, not this A. Okay. So because it came in at 360 and the tachycardia and the pacing cycle length was around 360. Okay, so it's an example of a long RP tachycardia, maybe superior axis because AVF is negative. Earliest A in tachycardia was at proximal CS. AA accelerated to the pacing cycle length. Stim to A minus B2 was around 150. PPI minus tachycardia cycle length was around 185. There was VAV response, and slowly decremental accessory pathway, and hence or not accessory pathway. In this case, slowly decremental retrograde limp, retrograde limp in AVNRT. Okay, so so let's just really briefly for the VAV or pseudo VAAV response. So you want to avoid confusion by identifying the last A. One more thing that you can look at is look at, if you have nice his signal, you have to look at the his signal. If the response was AH rather than AH, then if you see AH, then this is actually as if it's a VAV response. If you see AAH, it's as if it's a VAAV response. Okay, because like, for example, when you're entraining the an accessory pathway, so you're V-pacing, you're going up the accessory pathway, down the his, you'll see AH, okay? And we're V-pacing for example, you know, for example, an atrial tachycardia case, which is not shown here, you will go V, A, you know, V, retrograde his, A, antegrade his, V. So you'll get to see A, and then H. Okay. So V, his, retrograde, A, okay, and then the tachycardia A, and then his, and then V. So you'll get to see AAH, okay, with atrial tachycardia. Okay, so further examples. So you are V-pacing here, okay? You're V-pacing at 340. You're accelerating the A to A cycle length at 340 as well. You see here this is your V, this is your A that came in at 340. So you know this is your last A. So there's V, A, but then sometimes you see next thing that comes is VA on at the same time. Okay, so that's confusing. Is it VA response? Is it VA AV response or VA V response? You cannot, difficult to tell. But if you see his, then you know it's VA AV response or AH response. Okay, so this is why his is helpful. Okay, so you know this A went down the his and then into the V, because his came in earlier. So it's not A, V, A, and then tachycardia A, and then down the his. Okay, so this in this case is short RP tachycardia. Earliest A, it's very short RP tachycardia. VA is less than 70 milliseconds, most likely. So it's, you know, it's an AVNRT suspect. And then what makes it more likely it being an AVNRT is when you V-paced, the atrial activation is different, right? So this is your V-pacing. So you're going up the AV node. And then during tachycardia, your A is like, for example, here, so you see your his A here. Okay, so that's your A is earlier during tachycardia than during V-pacing. So subtle change. Okay. So stim to A minus V to A is long, so 210, again, AVNRT, PPI minus tachycardia cycle is 150, again, AVNRT. So there's VAV response or pseudo VAAV response because of the H that is present. So it's an AVNRT case. So far what we said so far. So when you're ventricular pacing, you want to, after you stop pacing, you want to look at the response after pacing, whether it's VAAV or VAV response. And if it's VAAV response, atrial tachycardia. If there's VA dissociation, it's most likely atrial tachycardia or AVNRT, because V technically is not part of the AVNRT circuit. If you see VAV response, then it might be AVNRT or AVRT. If you see manifest entrainment and during the transition zone, is AVRT most likely. However, if it's left lateral, you might not see this. You might not see. You might need to adjust the pacing side to manifest the entrainment. And then if you see fusion with and reset not simultaneous, so either fusion or reset without them both being together, then it's more atrial tachycardia or AVNRT. Okay. So one more example. So your V pacing here, you at 250 milliseconds, and the tachycardia cycle length is around 255. So you're just slightly, pacing slightly faster. Your QRS morphology is identical to your tachycardia QRS morphology. But since you accelerated the A, you know that you captured the V. The His is antegrade. You see, this is your His during pacing, and this is your His during tachycardia. So it's antegrade orthodromically conducting His. It's similar His, so you have to be fusing, although it's not showing in these 4 leads. Okay, so this is called concealed fusion. So this is an example of entrainment with concealed fusion, definite fusion, but not showing on QRS, okay, on the surface ECG. Okay, so longish RP tachycardia again, earliest A at proximal CS. The H is antegrade, same morphology, so hence there's an accessory pathway that's present because you're His pacing and you accelerated the A. Okay, His refractory PVC pacing and you accelerated the A to A interval. HV is normal, not pre-excited tachycardia. There's concealed fusion. V is part of the circuit. Stim to A minus V to A is around 30 milliseconds, and PPI minus tachycardia cycle length around 15 milliseconds, and VAV response, VAV response, and tachycardia continued. Okay. So in this case was septal accessory pathway. Another example of when you of V pacing that is with a QRS that's very similar or almost identical to the native QRS or tachycardic QRS. You're pacing at 340 milliseconds, and you accelerated the A to A interval at 340 milliseconds, and your tachycardia cycle is around 355 milliseconds. The A atrial activation looks very similar. So earliest A is at the distal CS, right? A to A accelerated, there's concealed fusion, like we said, because again, the QRS is the same, but there's definite fusion because of the A to A here being accelerated with same atrial activation. Okay. We don't have nice His signals in this tracing or the at the His catheter. The S to SA minus VA is around 26, PPI minus tachycardia cycle is around 5, and there's a VAV response and tachycardia continued. Okay, so this is since the earliest age of distal CS is an example of left accessory pathway. So we said that if you I just showed examples of entrainment with concealed fusion, i.e. the QRS you're entraining with a QRS cover that is exactly the same as the native tachycardia. And sometimes and then if you are entraining with the QRS complex of that is similar to the fully paced QRS, this is called concealed entrainment. Okay, so again, tachycardia is entrained, but entrainment cannot be proven because you cannot show fusion. However, you know that you entrained if you have antegrade His, so you know by definition there's fusion that is just not showing. It's not enough fusion to show on a 12-lead ECG. Okay, and if you have such a case, you might want to change the pacing side. If you pace at the base rather than at the apex, you may allow better chance for fusion because, for example, if you're pacing at the apex, you might the QRS very much would be like a fully paced QRS because you're not fusing, you're pacing probably before the native QRS exited the hypercondrial system. If you move your catheter more to the base, then you allow for the SVT QRS to manifest itself, and then you pace, and then you will fuse and you entrain the tachycardia. Okay, so you might allow for fusion when you change your pacing site. So obviously, if you pace at the, you have to pace closer to the accessory pathway to manifest fusion with entrainment. So best to pace from the LV for left accessory pathways and pace from the RV for septal right accessory pathways, base that is. Okay, so when you apical, when it's apical side pacing, concealed entrainment is more common. When you're base pacing, manifest or concealed fusion, or even concealed fusion, meaning you pace when the QRS is mostly the tachycardic QRS, because you pace just at the very distal end when the QRS is almost fully came from your native hypercondrial system QRS. Okay, so if you want to show more manifest or concealed fusion, you have to pace more at the base that we don't routinely do. Okay. Okay, sorry, we had technical issues. So furthermore, for one last maneuver that you might be able to do is parahesian pacing. So you want to aim for near field, large amplitude His and RV EGMs, and smaller, more far field A. You want to pace at high output and gradually lower the output. It would be nice if you have His recording in both the proximal and distal pairs. And then when you truly capture the His, you will have short stem to A. So this is your His. When you're truly capturing the His, you'll get stem to A and stem to B very short or close to each other. Okay, so now imagine you don't have a septal accessory pathway and you were capturing the His, and then you lost capture. You, in order to get up the A, so you'll go down the V and then up the A. So you will note prolongation of your stem to A or V to A. Okay, so this is called nodal response. However, if you have an accessory pathway that is septal specifically, and you lost the His bundle capture, there will be minimal, if any, change in your VA time because you have an accessory pathway here. Yes, you lost the His capture, but you will be able to go up the A through the nearby septal accessory pathway, so you will not manifest that delay in VA or stem to A as much. Okay, so if you did not see prolongation of your VA, then this is nodal response. If you did see, if you note prolongation of your VA, then this is nodal response. If not, then it might suggest there's an accessory pathway that's septal that is present. Okay. Obviously, if you have an accessory pathway that's further away from the septum, then you will have VA conduction time that prolonged even with His loss. So then that maneuver is only useful when you are trying to rule out His and septal accessory path that is close to the His. Okay, so you have to say it actually, you should say when it disproves the presence of septal accessory pathway. Okay, so you have to use such. If you perform this maneuver, it will tell you if there's a septal accessory pathway or not, specifically, not any other accessory pathways. Okay, so again, so now you have an SVT case. Just in summary, we pace into that tachycardia. We want to ventricular pace into that tachycardia to rule in or out atrial tachycardia relatively quick. So again, you pace slightly faster. If the atrial cycle is accelerated to the pacing cycle length and tachycardia continues after pacing is stopped, you want to see whether there's VAV response. fusion with reset, VAA, response, or if you dissociate the V's from the A's. Okay, all these things that you want to take note of. Okay, this is this algorithm that you might use to figure out a specific case. Okay, so thank you very much. It's a long lecture, but hopefully it was useful. It was by no means meant to be an extensive entrainment talk, but it's the beginning. And then with experience, you build on this. You can build on this talk. You have to practice so much, and please stop the video and review the tracings, because I went very fast because of the time constraints. Okay, thank you very much.